Let us now go to interview and history taking strategies. The topic is overcoming difficulties in provider-patient relationships. Some patient relationships will challenge the provider from their onset, such as initial encounters with patients who are angry or hostile. Even when a strong alliance has been established between the provider and the patient, critical events in the caregiving process and or the influence of significant others may challenge the stability and effectiveness of the relationship. For example, Platt and Gordon refer to a phenomenon known as the two-patient syndrome, in which a family member or significant other serves as a translator for the patient. In such a situation, the answers to the provider's questions may reflect the translator's perceptions of the patient's healthcare needs, status, and goals rather than those of the patient, especially if the family member or significant other is also the primary caregiver for the patient. Similarly, adverse clinical phenomena such as unexpected fetal loss, chronic pain that is unresponsive to treatment, or the need to inform the patient and family of a terminal diagnosis will test the strength of the most well-established provider-patient relationship. In order to successfully navigate challenging situations, recognize the feelings and behaviors being manifested by the patient, such as sadness, fear, anxiety, anger, or hostility. Recognition requires that the provider be an attentive listener and observer, and that they take the time to reflect and process what they see and hear. Recognition often begins with the perception of distance or strained communication in a relationship that has previously been characterized by warmth and a free flow of communication. When this occurs, stop the usual routine of the visit and share these perceptions with the patient. Identify the perceived behavior or effect and seek the patient's confirmation as to the accuracy of these observations. If the nature and source of the patient's behavior are still unclear, reassure the patient that you have listened to him or her but remain confused about why they feel the way they do. Ask the patient to help you better understand what they are experiencing. Do not become argumentative or defensive. Acknowledge and validate the patient's feelings as appropriate through the use of statements that convey understanding and concern, such as, "I can see where that would be frightening. Do you feel any better now?" Demonstrate empathy. Coulihan and Block define empathy as a type of understanding. It is not an emotional state of feeling sympathetic or sorry for someone. Being empathic means listening to the total communication with words, feelings, and gestures, and letting the patient know that you are really hearing what they are saying. For most, if not all challenges to provider-patient relationships, there is no quick fix, and attempts to implementing one are usually perceived by the patient as being dismissive of their feelings, thereby disrupting the relationship even more. Support and understanding are essential to building and maintaining a relationship. Touch may help convey understanding. If it is culturally appropriate and the situation warrants such an action, as in the loss of a loved one or when delivering an unfavorable prognosis, touch can be very therapeutic. Demonstrate hope. This is particularly important in situations involving poor prognoses. Although the eventual outcome may not be altered, the patient needs to know that the provider will not withdraw because cure is not an option. They will remain a consistent source of support and will help the patient to identify and achieve the life goals that are important in their remaining lifespan. Patients who are resistant to therapeutic recommendations represent another challenge to provider-patient relationships. Such resistance often represents a failure of the provider to fully engage the patient as a partner in decisions about their health care. Cultural norms and patient ambivalence may also be a major factor, as in patients who smoke. Smokers who have not experienced the negative health consequences of smoking often do not perceive themselves to be at risk, and their sociocultural environment may support continuation of this negative health behavior. The provider should continually assess the readiness of the patient to adopt or change the behavior or intervention and be ready to capitalize on any opportunity that may increase the patient's level of readiness. For example, a female smoker previously resistant to smoking cessation interventions may become very responsive if an abnormal pap smear causes her to be sent for colposcopic examination and she learns about the relationship between smoking and cervical cancer. The grandmother who smokes and cares for her grandchild while his parents work may be resistant to quitting for her own health, but may do so to protect the health of her grandson. Most practitioners are employed by healthcare institutions. Many institutional factors affect patient-provider relationships. Cost containment has led to an ever-increasing emphasis on productivity. Increasing patient volume often decreases the time allotted for initial and follow-up patient visits. If the time allocated for the patient sessions is inadequate to obtain all of the necessary historical data, the patient can be asked to complete a linguistically appropriate health history form before being seen by the provider. Prioritization of data collection is essential and is determined by the patient's expressed reason for seeking care as well as the presenting signs and symptoms. For example, although diet, exercise, and social history influence treatment decisions, the past medical history and a focused review of systems take precedence in the acute phase of illness. Thank you so much for your attention.